everyone. Well, thank you so much for joining us tonight for our webinar, What's in Your Bladder Cancer Pathology Report. I'm Teresa Blondin, the National Volunteer and Program Manager here at Bladder Cancer Canada, and I'm honored to be facilitating this session tonight. At Bladder Cancer Canada, we believe that education can help facilitate and increase quality of life for people affected by bladder cancer. So I'm pleased you're all here to empower yourself through education. So before we dive in, just a bit of housekeeping. Your mics and cameras will remain off for the duration of the session. However, we'd love to know who's here with us today, so if you're willing, please drop your name and location in the chat. And please remember that our webinars contain content intended for the sole purpose of information sharing and should not be considered medical advice. Always talk to your doctor and or urologist about what is best for you. And if you run into any issues, myself and my colleague Mary Lou Cameron are monitoring the chat and happy to help. So now I'm honored to introduce our presenter for the evening, Dr. David Berman. Dr. Berman is a professor of pathology and molecular medicine at Queen's University. His research focuses on basic, translational, and clinical aspects of bladder and prostate cancer, and he's also a valued member of Bladder Cancer Canada's Medical Advisory Board. So thank you so much for being here, Dr. Berman. We really appreciate it. So I'll give you a few seconds to get your slides up and running.
Okay. Just gonna pick out a pointer. All right. So I'm David Berman, and I've been introduced. I'm here with Grace Bowry, who is a student who's worked with us for a couple of years. And it's really my pleasure and our pleasure to speak to you tonight. Bladder Cancer Canada means a lot to us, and being able to do cancer research that is important for patients, particularly bladder cancer patients, is what makes it fun and compelling to get up and go to work every day. So we're going to talk about what's in your bladder cancer pathology report, focusing on early bladder cancer or non-muscle invasive bladder cancer. And there will be a subsequent talk by my colleague Dominique Trudel in Montreal on muscle invasive bladder cancer. So I've already been introduced. I'm a surgical pathologist and I specialize in urologic pathology. That means that anything that a urologist takes out of a patient, whether it's a biopsy or an entire organ, it comes to me to be evaluated under the microscope. And my email address is here. We'll provide the audience with a copy of this presentation, so you don't need to be furiously scribbling down notes. And I want Grace will introduce herself.
Hi there, my name is Grace. I'm a fourth-year nursing student here at Queen's, and I've been working in Dr. Berman's lab as a research assistant for about 2 years now. My work has gone through a couple different projects, and I'm really happy to be speaking here today.
She'll talk a little bit about her work later on. Well, but for now, Grace, to you.
Right. So 2 common symptoms of bladder cancer are blood in the urine, so hematuria, and dysuria, so painful urination. So these symptoms would have prompted you to go speak to your doctor and get evaluated. One of the methods which your doctor will use to diagnose a bladder cancer is cystoscopy. And this is where they insert a tool through your urethra and into your bladder to visualize your bladder. If they then can see a bladder tumor, they will remove it and send it to a pathology lab for further analysis.
So that's where I come in. The tissue gets processed and slides get cut and stained. They come to me. I look at them using a microscope and determine if there's cancer in the slide, because not all the lumps and bumps that the urologist thinks are cancer actually are. And if so, what is the grade and the stage of the cancer?
So one of the terms that Dr. Berman just talked about was cancer grade. Now, cancer grade is used as a prediction for how fast your cancer is going to grow or spread. So we have a picture of a speedometer here, and the higher the grade of the cancer, the faster that it is predicted to progress. So The grade is used as a prediction for your prognosis. So that's a term for predicting the course of your disease, including whether and how quickly it will improve or worsen.
So we found over in the past 100 years or so that grade is a good way of predicting prognosis. And in particular, in bladder cancer, we divide early stage lesions into low grade and high grade cancers. The low grade have the best prognosis, are the least likely to grow or spread or even to come back quickly after they're removed. So the low grade cancers on the left, and this is what I look at under the microscope. I look at these at the cells, and each cell has its own nucleus, which are these purple oval structures. And you can see that these nuclei are fairly uniform in size and shape. They all tend to look oval, and they even look like they're organized into columns, as if someone took a comb and just combed in this direction and aligned all the nuclei. And that's to be compared and contrasted to high-grade cancers, where the nuclei are a lot more crowded and jumbled. They go in all different directions. There's more variation in nuclear size and shape, some small ones, some bigger ones. And there are these cells that are undergoing division. They're dividing, making new cancer cells. And they are recognized by making these kind of eyelash or spiderweb looking structures. They're called mitotic figures. And they're an important measure of how quickly a cancer is going to be growing, and they're highly correlated with prognosis. So based on grade as one of the major determinants, patients with low-grade, low-risk cancers will undergo infrequent surveillance and stop surveilling after a while. And by surveillance, I mean repeated examinations with the cystoscope, the camera that goes in through the urethra and examines the bladder. Whereas high-grade cancers are recommended for more frequent cystoscopy or surveillance, as well as intensive immunotherapy, especially with BCG that gets squirted into the bladder and held there for hours, as many as 24 times on different days during a patient's treatment. So it turns out, somewhat surprisingly, that at least to most patients, and to me when I first heard it, that pathologists, even the most expert urologic pathologists who specialize in bladder cancer and see many cases of it every day when they practice, our agreement rates are not what you might think. So this is a study we did with, and it was funded by Bladder Cancer Canada. We're very grateful for their partnership in our work. We took 80 cases, and we had 3 different centers or 3 different pathologists grade each case. And we found that our grade was that these other pathologists at UHN, Dr. Vanderkwast, and at University of Pennsylvania, Dr. Lal, agreed with us about 80% of the time. But they only agreed with each other 66% of the time, which means the remaining 1/3 of patients would get very different treatment, treated as a low grade or a high grade, depending on which pathologist happened to see their sample. And this is a little bit concerning, and we think we ought to be able to do better. And we also want to remark that if you were to go to a typical community hospital, you'd have a pathologist who is looking at slides from all over the body and all types of diseases, and wouldn't be as highly trained in urologic pathology or bladder pathology. So the agreement rate would probably be less good. So,
Right. So now that we have talked about cancer grade, we'll talk a bit more about cancer stage. So this is a term that describes how far that the cancer has progressed through the layers of your bladder or throughout the rest of your body. So in this picture here, we have a truck that has kind of veered off of the road, and it's going deeper off the side of the cliff. That's kind of like a way of describing how deep the bladder cancer has gone into the different layers of your bladder. So looking at the different layers of the bladder, we have the innermost lining of your bladder, which is known as the urothelium. After the urothelium, we have the lamina propria, which is a layer of connective tissue. And following the lamina propria, we have a layer of muscle and fat. So if your cancer is diagnosed as a non-muscle invasive bladder cancer, it will fall into the TIS, TA, or T1 category. So it's going as far as up to the connective tissue layer of the bladder. Whereas cancers that are diagnosed as muscle invasive cancers, they dive deeper into the tissue, into the muscle layer and beyond.
So just to reiterate, this IS is a code or shorthand for carcinoma in situ. So that's the flat version, and we'll be talking about it a little bit more in a minute. TA is papillary, T1 is either one once it's gone into the lamina propria, and then T2 and above are muscle invasive. So papillary bladder cancer is the most common type of bladder cancer. At first diagnosis, it represents 75% of cases. And the term papillary comes from the Greek word papilla, which means an extension or a growth. So these extend, they look like little trees or broccoli florets, and they extend into the space where the urine is stored inside the bladder. They recur, meaning that after they're fully removed through the cystoscope, at a later date, the urologist will find another papillary cancer in half of the cases, which is a lot, but they're generally controlled by local treatment. And they have an excellent prognosis, particularly when they're low grade. Carcinoma in situ is, in situ means it's in place. It's kind of, the cancer is in the place where it started. It's just replacing the flat urothelium, the benign urothelium, with malignant or cancer cells. It's less common, and it's a little bit, it's actually more aggressive, higher risk of coming back after removal, harder to get rid of, and higher risk of invading either into the connective tissue or even into the muscle.
So at the end of the day, whether the tumor is flat or papillary, the depth that it is traveling into the layers of the bladder will determine how frequently that surveillance will need to occur and different types of treatments. So on the left side here, we have the non-invasive cancers, and they'll be most likely given a local treatment and less frequent surveillance with the cystoscope. On the right side here, we have the invasive cancers. So they're diving deeper into the muscle layer of the bladder, and they're going to require more radical treatment. So that could be removal of the bladder, radiation, and systemic chemotherapy. So overall, today we've talked about non-muscle invasive cancer and muscle invasive cancer, and we've described both the grade and stage. So bladder cancer grade is a prediction of how quickly the cancer is going to progress, and cancer stage is a marker for how far the cancer has gone into the bladder. From there, grade can be divided into low grade or high grade based on the characteristics of the cell, and non-muscle invasive cancer can be divided into carcinoma in situ, TA, and T1 cancers, whereas the muscle invasive cancers are T2 and beyond.
So we're going to talk just a little bit about some of the research in the lab that relates to the project we just to the material we just presented. So I'm going to talk first about quantitative grading, which is a project that was initiated with Bladder Cancer Canada funding, and is now funded by the Ontario Institute for Cancer Research. And this is an approach to making bladder cancer grading more objective, so that pathologists will agree on the grade much more frequently, and then also to make it do a better job of predicting whose cancer is going to come back slowly or not at all, versus whose cancer might come back more quickly, or even we use the word progress, but that means essentially grow and spread. So this is relatively recently developed, very powerful computer technology where the computer recognizes every cancer cell nucleus. And in this image, it shows most of the nuclei are circled in white. And it gives us all sorts of information about each of those nuclei, including their size and shape and texture, position, and all of the information we would need to grade it and more. And then we have other nuclei that are circled in green, and those are recognized as undergoing division or proliferating because they have they appear as mitotic figures where they look like eyelashes or spider webs. This is a feature of their chromosomes getting ready to separate into two different sets, and one nucleus becomes two nuclei. So this technology will be available on pathologist desktops all over the world in the next few years. It's already available in a select group of places. We don't have it for clinical use yet. I don't think anybody in Canada is routinely using something quite this advanced, but we're getting close. And we've published our results showing that we can actually make quantitative rules for grading and make grading into something that's a measurement rather than just a judgment call, which it still is and has been up till now. And that's because we have a list of features that we're supposed to evaluate that tell the difference between low-grade and high-grade cancers. And there's too many of them on this chart for you to read, but I'll just give an example. So mitoses, those are those proliferating cells that were circled in green on that image. Low grade has occasional mitoses, and high grade usually has frequent ones. Well, what's the difference between occasional and frequent? And there's a million other questions like that. We've done the research, and we're able to draw some quantitative conclusions. So, for example, for mitotic figures for those proliferating cells, this is about 0.02. I guess it's about 2 in 1,000 cells or more will give you a high-grade cancer, and those below that rate are much more likely to be low-grade. So we can accurately grade on the basis of mitotic index. We can get grade almost as accurately as pathologists can. And then the same thing is true for variability in nuclear size. We get about 80% accuracy just in separating cancers on the basis of how variable the nuclear size is. So we can put these into different models and make grading more precise. And something that's even, I think, more exciting is we can train based on historical data of how long a patient remains free of recurrence after their first bladder cancer has been removed. We can train new grading algorithms using these same measurements. So on the left is how well regular pathologist grade distinguishes between those patients who recur slowly and those who recur quickly. So at let's say, 5 years, 50% of the low-grade patients have recurred, and about 60% of the high-grade patients have. And the low-grade patients do recur more slowly than the high-grade, but the difference is not very dramatic. But when we use our computerized grading system and we change the rules to best reflect how quickly we knew cancers came back after resection, we can identify patients whose cancers don't recur even for 7 years. And we can identify a high-grade group that recurs a bit faster than they did in the conventional grading scheme. So this is technology that's in development. It's certainly not ready yet, but we have made a lot of progress, and it's an exciting thing for us to be working on. Our aim is to better identify those patients who don't need frequent surveillance, and maybe even stretch out the time between cystoscopies, let them avoid BCG, and make sure that those who do need it get what they need. Okay, this is Grace's project.
So taking all of the information that Dr. Berman just spoke about, as a nursing student, I wanted to know, what are the patient's perceptions about their non-muscle invasive bladder cancer pathology? Before I go into my project, I'd like to thank Bladder Cancer Canada for distributing our survey and recruiting participants for us. So in the graphs displayed below, we have the perceived understanding of participants with non-muscle invasive bladder cancer about their grade and their stage. So to get this information, we distributed 2 surveys to participants. And in each of the surveys, participants rated on a 1 to 5 scale their understanding of grade and stage. So in the light orange color, we have the number of participants who rated each score before and after the viewing of the Bladder Cancer Guidebook from Bladder Cancer Canada, and particularly the pathology section. So what we learned from these scores is that there was an improvement of the participants' knowledge before and afterwards for both grade and stage of bladder cancer pathology. But beyond the numbers, we wanted to see and sample some written responses from the participants who took this survey. So the first theme that we developed from the participants' responses was that there is a large variance in the understanding of what happens in pathology. So for example, we had one person say they have a lay person's understanding of how samples are processed and reviewed by pathology. On the other hand, we had one participant here who stated they had a very solid understanding of what a pathologist does, and that they look at abnormal cells that helps them determine the grading that they give the cancer. Given that information, there was a large reliance on the subjective expertise for cancer trajectory in the participants. So we had one participant say, I had never expected that the diagnosis would vary amongst pathologists, but I can certainly understand why. With the technological innovation that Dr. Berman just mentioned, we had a large theme of enthusiasm for technological innovation. We had a participant say, as computer analysis improves, so will the subsequent diagnosis and treatment. And lastly, with whatever education methods that are used in the future for bladder cancer pathology communication, there is a great importance of timely, reputable, and accessible information for the patients.
So there's always more to learn, and we maybe haven't answered all your questions. We just want to point out there's some really good information out there. And again, we'll be sharing this presentation through Bladder Cancer Canada, so you don't have to write all this down. But Bladder Cancer Canada itself has forums, guidebooks, support, and videos. And there's also mypathologyreport.ca, which is a Canadian website with terrific information, lay-friendly explanations and really beautiful drawings, illustrations of a number of diagnoses that one can find in the bladder, including the ones we went over today. So we're going to stop the presentation here, and we'd be more than happy to take questions.
Great, thank you so much, Dr. Berman and Grace. That was a lot of information, and I know there's a lot of confusion about staging and grading, so I'm sure this will be very helpful to our community. So we will open the floor to questions. You're welcome to type any questions into the chat, and I will do my best to read them out to Dr. Berman. So a first one that came in, a biopsy report that states muscularis propria present without invasion, and another that states muscularis propria present. Can you provide any clarification on the difference?
Yeah, so since the involvement of the muscularis propria is a very important factor for pathologists to evaluate, the urologist wants to make sure they're sending us some muscularis propria so we can tell them whether there's any cancer in it or not. So if there's cancer in it, we would say the cancer involves the muscularis propria. If there's no cancer in it, we'll say we saw it, it's there, and there's no cancer in it. And there's various ways to say that. Sometimes we say the muscularis propria is identified and uninvolved. Sometimes we'll just say it's present. Usually if the cancer is not invasive at all and we didn't use the term invasive, then we figure we imply it can't get there without invading. So we just say it's there, we saw it.
Okay, great. Asking you to help dive into this pathology of a urinary bladder. Sarcomatoid urothelial carcinoma, high grade, with osteoclast type giant cells, positive for invasion of muscularis propria, and margins of resection clear of tumor.
Okay, so bladder cancer is one of the cancers where, as it enlarges and gets more aggressive and gets to the point where it can invade the muscularis propria, it starts to lose, it starts to sort of undergo an identity crisis. There are molecular mechanisms known for this, but every cell, normal cell in the body, has a number of mechanisms by which the DNA is regulated so that a normal bladder cell will only express the genes and proteins that it's supposed to, that make it behave like and look like a bladder cell. So once a cancer gets to a certain stage, it starts to lose those qualities, and it'll start to adopt or express or make proteins that resemble other cell types in the body, or it'll just lose the ones that a normal urothelial cell would typically make. So sarcomatoid is a term that means that the cell no longer looks to be epithelial. It no longer looks like it's serving the purpose of excluding liquids from the outside of the body, keeping them from going back into the body, which is the urothelial cell's main function. And it starts to look like connective tissue, which is a completely different cell type. So connective tissue cancers are called sarcomas. And because this is coming from an epithelial cell, we call it sarcomatoid, meaning it looks like a sarcoma, but it's not. And the osteoclast differentiation is further non-epithelial appearance of the cells, where they're starting to look like they make bone, where they're starting to act like bone cells. It's a very interesting, it makes the cancers difficult to treat and difficult to recognize, but from a scientific point of view, there's some interesting research going on to understand why cells do this, and can we find sort of Achilles heels. Does this make them vulnerable to kinds of therapy that they wouldn't otherwise be vulnerable to?
Okay, thank you. My pathology report was done by a gross pathologist or a technologist. Can you clarify what that means? Who was involved?
So typically when a specimen comes into the pathology laboratory, either a resident or a gross pathology technician, and there are many different terms for these people, pathology assistants would be one, will evaluate the specimen. By gross, we mean with the naked eye, without microscopy or magnification. So they'll evaluate what it looks like by the naked eye, and based on that evaluation, they will choose whether to submit all of it or just some of it for microscopic examination, and how to place the tissue into the receptacles for processing such that it presents the best information to the pathologist, so we can evaluate the stage and the grade, and also whether all of the cancer was completely resected or not. So there should also be an accompanying pathologist report in addition to the gross description. Usually it's a partnership between those two people. It's not very often that the same person. We use the term gross as a verb, like gross is the tissue, meaning got it ready for histologic examination. That's usually not the same person as the one who's actually looking at it under the microscope. And to make things even more complicated, there's usually a few other people who are involved in actually preparing microscopic slides, in between the person who grosses it and the pathologist who examines it under the microscope. We will go look at the specimens, particularly the complex ones, when they arrive in the laboratory, to help us understand the context, but we're not doing all of the manual processing. Right.
Okay, another pathology question, if you can help explain. Partially ulcerated urothelial mucosa with inflammation and reactive features. The tissue shows a reactive spindled cell proliferation as well as multinucleated giant cell reaction.
So that would be a typical report after somebody had BCG or particularly BCG, but maybe sometimes even after having had a previous resection. So the bladder's trying to heal. The multinucleated giant cells are groups of cells that are trying to get rid of material that doesn't belong there, which could be scar tissue, or the BCG treatment itself is seen as a foreign body that needs to be gotten rid of. So that's in and of itself it doesn't sound worrisome to me. I wouldn't generally use the term spindle cell proliferation, because that might imply that they think that there's some kind of neoplasm, like there's independent growth of spindle cells. I would just generally say that there's a scarring reaction. I hope they don't mean something else. I would need to ask them to be sure, but the most likely, in most cases, that report would just be what one might expect after BCG treatment and resection. And if that's the history of this patient, then they might want to ask their doctor about it, but I wouldn't worry about it.
Okay. Currently, can a Canadian patient have their tumor slides regraded outside of Canada using the new quantitative method? And if so, how could a person identify these sites, or does it depend on how old your slides are?
So this thing we're working on, as far as I know, is the only one available, and it's not been implemented in a clinically usable fashion yet. We have the data models, and we're working on the actual software algorithm and the software to be able to apply it to whole slides. Once it is available, it should work on old slides and new slides. But there's a lot of steps along the way, and I'm sorry research takes a long time.
Okay, we will take a few more questions here. Okay, so I was advised I had non-muscle invasive high-grade papillary and carcinoma in situ. There's no invasion of the underlying lamina propria. Would that mean cancer stage as TIS and TA? That wasn't on her report, she's saying.
Yeah, so pathologists have a tendency not to provide the stage, only the sort of like the information necessary to deduce the stage or assign the stage. There are some situations where we get forced to stage it, and there's something called synoptic reporting, which generally will generate a stage, but unfortunately we don't usually put those in, and I think we should, but it's a good habit we haven't adopted yet. I apologize.
I think we will leave it there. So I hope everyone enjoyed this session. As I mentioned, in July, we're hosting a webinar on the disability tax credit with Rosemary Hill. Registration is open for that now. And our next English webinar is planned for September. So if you subscribe to our e-newsletter, you'll get all of the information on that. And as I mentioned, the French comparison to this, the partner to this, will be held on the 19th of June. So that will be subtitled in English. So in the chat, Mary Lou will share a link to register for these sessions, as well as a quick feedback survey, and that will come through email as well tomorrow. We'd love to hear your thoughts on this session and any suggestions for future presentations. We'd really appreciate if you take a few minutes to complete that survey. If you'd like any accommodations to complete the survey, or if you have any additional comments or questions, you're always welcome to call us at 1-866-674-8889 or email info@bladdercancercanada.org. And a recording of the session will be uploaded to our website in the coming weeks. And of course, we hope you can join us for Canada Walks for Bladder Cancer on September 21st or 22nd. You can step out anywhere, anytime as well during the month of September to help raise funds for bladder cancer research support programs and help raise more awareness. So visit bccwalk.ca for more information. So thank you again, Dr. Berman and Grace, for breaking down this really complicated piece of bladder cancer. We're really grateful.
Thanks a lot for having us. Have a wonderful evening.
Have a good night, and thank you everyone for attending. Good night.